I'm Susanna Proudman. I'm a rheumatologist at the Royal Adelaide Hospital, and the purpose of this presentation is to provide an overview of the principles of history and examination required to assess a patient presenting with joint pain. Many symptoms may indicate a musculoskeletal condition. Pain is an obvious symptom. This may be both focal within a joint and more generalised. Swelling of either the joint or muscle or other musculoskeletal structures. Stiffness in spine or limbs. Loss or limitation of function, deformity of a joint, instability or locking of a joint, weakness, constitutional symptoms such as fatigue, malaise, and at times even fever, and a wide range of extra-articular features that are often typical of different specific multi-system diseases, which can also give rise to arthritis. And of course, any chronic disease may be associated with psychological effects and sleep disturbance, which may also have a negative effect on the experience of musculoskeletal conditions such as chronic pain. There are a number of different tissues within the musculoskeletal system which may give rise to pain in rheumatic diseases. There are those that arise from non-articular sources such as muscle spasm, inflammation, injury and infection, nerve irritation or compression, bone fractures or spurs, stretched or torn tissues, referred pain, and the so-called complex regional pain syndromes, which are a form of neuropathic pain. And of course, there are articular structures which may also give rise to pain, including inflammation within the synovium, potentially loss of articular cartilage and change in the biomechanics of the structures around the joints, and ultimately joint failure. The most common cause of pain in rheumatological conditions relates to inflammation. On this cartoon, you can see a number of structures within this normal diarthroidal joint. By this, I mean a joint that consists of two bones which meet at a joint which is lined by a single cell layer of cells called the synovium within a fibrous capsule. The two bony structures are lined by articular cartilage, and within the space there may also be a few mils of synovial fluid, at least in a joint the size of a knee joint. Outside the fibrous capsule, there are a number of other structures where you may also find synovium, and this includes within the tendon sheaths that sit outside the tendons attached to muscles, and also within small bursae or little cushions that sit beneath tendons and bones to improve lubrication when the joint is actually moved. The fibrous tissues, which include both the joint capsule and the tendons attached to bone, and this site is called the enthesis. So inflammation, seen on the right-hand side of the slide, as occurs in rheumatoid arthritis, can occur in synovial tissues, be that within the joint, in the tendon sheath around the tendons, or within the bursa. And all of these sites of inflammation will lead to pain, swelling, heat, redness and stiffness within a joint, which may have a reduced range of motion that leads to a loss of function for the individual. There can also be inflammation at the enthesis, and this is called an enthesitis or enthesiopathy, and it is particularly characteristic of the rheumatic diseases known as Spondyloarthritides. A good example is ankylosing spondylitis. The end result of the inflammation may be damage to the cartilage and subsequently the underlying bone, and this lesion is called the erosion, which is the hallmark of many inflammatory joint diseases, particularly rheumatoid arthritis. Each of the cardinal features of inflammation are due to a particular pathogenic mechanism. For example, edema or swelling is associated with increased permeability of the postcapillary venules. Warmth and erythema are due to local arteriolar dilatation. Pain is due to the action of numerous inflammatory mediators and cell-derived products on local nerves. And loss of function occurs due to restricted range of motion. So when assessing a patient and wondering if they have joint inflammation, the characteristic features include pain, swelling, heat, redness, and loss of function or range of movement. In addition to these 5 pathognomonic features, there may also be early morning stiffness for more than an hour, which has a diurnal variation, meaning that it is more severe, usually in the morning after prolonged periods of rest, and improves over the day with increasing activity. A variation of this is so-called gelling, which is stiffness after a period of immobility, usually lasting only a few seconds to minutes, which is characteristic of osteoarthritis, which, although considered a non-inflammatory condition, does have some inflammatory features, including this gelling type of stiffness. Inflammatory joint pain can also be aggravated by rest and is often accompanied by increased stiffness, as mentioned. It is often relieved by activity, giving rise to that diurnal variation to pain and stiffness that occurs over the day, and also relieved by non-steroidal anti-inflammatory drugs. It may also be accompanied by constitutional symptoms, fatigue, weight loss, fever, and sweats. The aim of taking a history in a patient presenting with joint pain and an examination is to determine the following. Is the pain articular or non-articular? Is it arising from the joint or from structures around the joint or even distant to the joint, such as referred pain to the shoulder from a subdiaphragmatic inflammatory lesion? The intention is also to determine whether it is inflammatory versus non-inflammatory, the chronology of the disease, the pattern of the joint disease, various risk factors, presence or absence, that may be associated with different forms of arthritis or rheumatic diseases, and likewise extra-articular features which may occur with some of these multi-system diseases, of which arthritis is one of the main features. So when taking a history, the aim is to understand the presenting complaint, to ask open-ended questions to gain an insight into the problem, and then to ask more focused questions to understand the complaint in more detail. And in doing so, you're understanding the chronology of the illness, the functional impact on the individual in terms of their activities of daily living and other activities that are important to their quality of life, such as the ability to work and care for others and to participate in social activities. Obviously, demographic features such as the age and sex of the individual may represent risk factors for certain types of arthritis over others. Other lifestyle factors may be associated with certain forms of arthritis. For example, obesity may be associated with osteoarthritis of large weight-bearing joints. Past history of other conditions or other coexisting medical conditions may also be important risk factors for rheumatic diseases and may have an impact on your choices for future therapy. A full and comprehensive review of systems is essential to understand rheumatic diseases, which by their very nature are often multi-system diseases with multiple symptoms, of which arthritis is only one. Drug history is important both to understand potential risk factors for arthritic disorders, but also to understand potential interactions with choices for therapy for the rheumatic disease in the future. And family history is important, as a number of rheumatic diseases have a strong genetic link. So the open-ended question, telling me about your pain rather than point to where the pain is a rather simplistic example, but asking the patient to tell you the story without interruption for a good minute and a half can be very instructive in trying to understand the presenting complaint. While the patient is talking, observe their gait, when they come into their room, their posture when they're standing and when they're sitting, and their general movement, as well as any aids or other assistance that they require to move around the room. Their overall appearance will give you insights into whether there are other extra-articular features such as rash, and their general demeanour in terms of understanding the impact of these symptoms of a rheumatic disease, including pain, on their general level of comfort. So in exploring the joint pain in more detail, it's important to understand the characteristics of the pain. For example, is it an inflammatory type pain, which may have a more throbbing characteristic, versus neuropathic pain, which tends to have a more burning nature. Take a history about events that occurred before the onset of joint pain to try and understand whether there were any specific triggers or prodrome, as may occur in infectious cause of arthritis. There may be a history of trauma, certain drugs that have been commenced, or a history of dehydration that may be a trigger for some conditions such as gout, for example. Questions about the time frame, both in terms of onset, such as a sudden versus gradual onset, and duration of symptoms, be it acute, measured in days, subacute, measured in weeks, or chronic, measured in months, can help you develop a differential diagnosis for this presentation, which will narrow down the possible causes of these joint symptoms. A history of the periodicity, for example, does it occur every few weeks, or does it change over the course of the day? Is it worse at night? Is also very informative. Night pain in particular can be an indicator of a more sinister cause such as malignancy, and may be considered a red flag in some instances. A history of aggravating and relieving factors, for example, activity, may be an aggravating factor in mechanical causes of joint pain, whereas rest, as mentioned, may increase inflammatory pain. And then understanding the pattern of joint involvement is extremely important in helping you develop a differential diagnosis. For example, what is the pattern of spread? Did the joints slowly become involved in an additive fashion, or was there a migratory element to it? Did one joint become involved, start to improve before the inflammation moved on to another joint? Importantly, the pattern of involvement, particularly whether there is involvement of the axial skeleton, both the spine and the thorax, is key to identifying the group of disorders known as the Spondyloarthritides. Peripheral arthritis can occur in Spondyloarthritides, whereas axial involvement is much less common in other forms of arthritis, such as rheumatoid arthritis. Describing the pattern of arthritis can also be referred to in terms of whether the joints are proximal, in general larger joints, versus distal, generally smaller joints. Whether it is a symmetric or asymmetric pattern may also be very informative. And then describing the number of joints that have been affected. A polyarthritis is generally thought of as involving more than 5 joints, monoarthritis a single joint, and oligoarthritis between 1 and 5 joints. It's also important to identify whether there's any clinical evidence of enthesitis or enthesiopathy, which is very characteristic of the Spondyloarthritides, as mentioned. And in this slide here, you can see, this image here, you can see inflammation at the insertion of the Achilles tendon into the back of the calcaneum at the heel. And this is due to inflammation at the insertion of the Achilles tendon where it attaches to the bone. And as mentioned, is very characteristic of Spondyloarthritides. There are a number of other sites for enthesitis, particularly in spondyloarthritis. For example, the annulus fibrosus, which is the fibrotic capsule of the intervertebral disc, is a common site of inflammation causing spondylitis in spondyloarthritis. Inflammation at costochondral junctions and the insertion of other ligaments and so on may also be a feature of Spondyloarthritides. And then to complete the history, it's important to ask the patient about the impact of these symptoms on their quality of life, their function, their ability to work, and as mentioned, a full review of systems and the impact on sleep and mood. Having developed a picture of the form of arthritis, pattern of arthritis, other extra-articular features, you may be beginning to get a sense of what the potential causes could be. So exploring risk factors may strengthen the case for a particular type of arthritis. For example, understanding where the person was at the time, whether any events occurred before the arthritis, such as an episode of infection or a trigger for an infection, such as travel, being associated with mosquito bites, for example, Ross River arthritis, or other more exotic forms of arthritis, such as chikungunya arthritis, which may be associated with travel in Southeast Asia. Food poisoning causing gastroenteritis may be a cause of reactive arthritis, which is one form of spondyloarthritis. Sometimes vaccines such as the flu vax can trigger inflammatory joint symptoms, and other forms of sexually transmitted disease, infections such as sexually transmitted disease may also give rise to reactive arthritis, particularly chlamydia and the causes of non-specific urethritis, urea plasma ureolyticum. There are other risk factors for different sorts of arthritis, such as past history. Has this occurred in the past, such as a history of gout? Family history, such as a family history of rheumatoid arthritis, gout, connective tissue diseases or ankylosing spondylitis, or psoriasis. A history of smoking and obesity are risk factors for rheumatoid arthritis, as is gingival or gum disease. Now, each different type of arthritis, and I've listed some here: infection, rheumatoid arthritis, the spondyloarthritis, connective tissue diseases, and paraneoplastic diseases, have associated extra-articular manifestations, which need to be sought on a full review of systems. For example, a viral infection may be associated with a prodrome of fever and rash before the onset of arthritis. Sepsis may be associated with a very acute onset of high fever, very severe joint pain, and there may be a history of a portal of entry of infection, for example, a wound elsewhere on the limb. And in reactive arthritis, there may be a history of previous diarrhea indicating gastroenteritis, or a urethral or vaginal discharge suggesting a sexually transmitted infection. There are a range of extra-articular features in rheumatoid arthritis, including subcutaneous nodules and episcleritis causing red eye, and I'll discuss this in a bit more detail shortly. In spondyloarthritis, there may be a history of psoriasis, uveitis, conjunctivitis, urethritis, or inflammatory bowel disease, and there's a range of symptoms that may be indicative of connective tissue diseases listed there. A paraneoplastic presentation is quite unusual and requires a detailed history of all the symptoms, as I have seen patients presenting with, for example, lung cancer, with an arthritis that looks like rheumatoid arthritis, so history of smoking, chronic obstructive pulmonary disease, a new cough, hemoptysis, and other features of malignancy may be an indication that the new onset joint pain is actually due to an underlying malignancy. The musculoskeletal examination is demonstrated in a separate video, the rheumatological approach to the musculoskeletal examination, but the general principles are listed here. In keeping with the general theme that a full rheumatological assessment must include the history and examination of all potential systems, as they may be involved in many different rheumatic diseases. A general physical examination is an important part of the rheumatological exam, and this includes vital signs, especially weight, height, and temperature. Specific musculoskeletal examination includes examination of joints as well as muscles, and the insertions of tendons, the entheses. Looking particularly for inflammation, the features of inflammation as previously listed. The approach to assessing joints you'll be familiar with from specific videos examining, teaching you how to examine individual joints, but the look, move, feel principle also applies here in the rheumatological examination. This may then provide further evidence for some of the features you were seeking on history, such as peripheral versus axial distribution, proximal versus distal, symmetric versus asymmetric, the type of arthritis based on the number of joints and the involvement of the entheses. And then, of course, a full extra-articular manifestation, a full examination to seek extra-articular manifestations in other symptoms is crucial. So what do we expect the medical student to know by the end of the musculoskeletal medicine attachment? In third year, we reviewed the GALSY examination, and this is a basic overview that familiarises you with the examination of the musculoskeletal system and is appropriate for use in a person presenting with no musculoskeletal symptoms, and is simply a screen to ensure that there are no underlying musculoskeletal conditions that might have otherwise been missed. For example, in a patient presenting with a typical syndrome of myocardial ischemia, they may well also have other causes of shoulder pain, for example, in the musculoskeletal system, not simply referred pain from myocardial ischemia. In a patient presenting with symptoms suggestive of a rheumatological disorder, a comprehensive musculoskeletal examination, as just outlined, is required. And in essence, the aim of the examination is to determine whether there's any inflammation in any joints and its consequences. So inflammation in general is defined as joint margin tenderness and swelling. It may be associated with a restricted range of movement, and if there's been damage in response to the inflammation, there may well be joint deformity. And of course, the extra-articular features of systemic musculoskeletal diseases, as mentioned. At the end of the Year 4 musculoskeletal medicine rotation, it is important to master regional examinations involving hands and wrists, hip, knee, shoulder, foot and ankle, and there are videos on all of this on Canvas as part of this program. There were also videos to view on the GALS and the rheumatological approach to the musculoskeletal examination. So having gleaned all of this information about the presentation with joint pain, it's possible to develop a classification syndrome of arthropathy based on all these features. Firstly, identifying whether the presentation is inflammatory or non-inflammatory will help determine the type of arthritis, and further separating the presentation into acute or chronic based on the duration of symptoms and the onset. And then within each of these groups, based on the number of joints involved and whether there is axial, namely spinal involvement, it is possible to come up with a short list of possible explanations for the presentation. And I'm going to go through some of these in more detail. Of course, once you have a short list of potential causes of, for example, an acute inflammatory monoarthritis, by looking more closely for extra-articular features as well as the distribution of joints affected, will allow you to shorten that list even further. So I will mostly be discussing inflammatory causes of arthropathy, both acute and chronic. And you can see that also the similar principles apply when assessing non-inflammatory arthropathy, and some of the causes are listed here. So turning firstly to inflammatory arthropathy, the differential diagnosis of a monoarthritis, either acute or chronic, is listed here. So the two most important causes of an acute monoarthritis occurring spontaneously is septic arthritis or crystal-induced arthritis. Occasionally trauma or hemarthrosis occurring spontaneously in a patient who is over-anticoagulated or who has a coagulation disorder such as haemophilia may cause an acute monoarthritis, and occasionally reactive arthritis, particularly due to a sexually transmitted infection such as chlamydia, may present with an acute monoarthritis. Chronic causes of monoarthritis include osteoarthritis, opportunistic infections such as fungal infections, and malignancy. Turning now to polyarthritis, which can overlap a little bit with oligoarthritis. This differential diagnostic list is quite a lot longer. Broadly speaking, they're listed here infectious, and these tend to be acute. And you can see a number of different viruses listed there which can cause an inflammatory polyarthropathy. Post-streptococcal arthritis due to rheumatic fever is in fact an autoimmune response to the streptococcal infection, and this may occur a little bit later but is often still an acute presentation. And Neisseria, which is a gonococcal infection, may also cause an acute polyarthritis. Crystal-induced arthritis is often a monoarthritis as mentioned, but sometimes it may also cause an oligoarthritis or a polyarthritis. whether it be due to polyarticular gout, as shown in this picture here, with inflammation in the distal interphalangeal joints, or calcium pyrophosphate deposition, which causes a pseudo gout type picture, often in very elderly women, affecting the wrist or knee. As mentioned, the different forms of spondyloarthritis, rheumatoid arthritis, and connective tissue diseases may also cause a polyarthropathy, although these do tend to be more chronic. For example, rheumatoid arthritis generally tends to be with a duration of more than 3 months, although occasionally patients may present with an acute polyarthritis, which over a period of time becomes apparent that rheumatoid arthritis, which is predominantly a diagnosis of exclusion, is the most likely cause, particularly if there are characteristic features such as autoantibodies or extra-articular features. In general, this presents with symmetrical polyarthralgias involving the small joints, the peripheral joints of the hands and feet, particularly the metacarpal and metatarsophalangeal joints. So it is a form of polyarthritis with all the features of inflammation you would expect. And in this photograph here, you can see inflammation of the proximal interphalangeal joints and some puffiness of the metacarpophalangeal joints, which is characteristic of rheumatoid arthritis. As mentioned, there's a large range of extra-articular features that can be present in rheumatoid arthritis. These are much less common these days, given the emphasis on early identification and treatment before many of these extra-articular features develop, although occasionally they can occur before the arthritis. And these include episcleritis, which is a cause of red eye, rheumatoid nodules seen on the border of the elbow, interstitial lung disease and other pulmonary manifestations, including nodules, pleural effusions, pericardial effusions, peripheral neuropathy, and vasculitis and other types of rash. In this instance, you can see small vascular lesions in a distribution around the nails. Another cause of a recent onset oligopolyarthritis, which may also have a more chronic presentation, is spondyloarthritis. The 4 main groups are psoriatic reactive arthritis, ankylosing spondylitis, and that associated with inflammatory bowel disease. And these are generally characterized by a spinal and/or sacroiliac joint, that is axial joint involvement. And you can see here some changes characteristic of ankylosing spondylitis. Instead of the normal concave anterior border to these vertebral bodies, you can see squaring of the shape of the vertebral bodies, which in time is associated with new bone formation at the site of the annulus fibrosus around the intervertebral disc, that is at the enthysis, as mentioned earlier, that leads ultimately to fusion between the vertebral bodies, the so-called bamboo spine. And these patients often have a peripheral arthritis that is asymmetrical and more commonly affects the lower limb than the upper limb. There are a number of characteristic features. For example, arthritis of the toe interphalangeal joints is quite uncommon and may suggest a spondyloarthritis, although occasionally it can occur in osteoarthritis. This associated with tenosynovitis and sometimes a true periosteal reaction that is only evident on X-ray may give rise to the so-called sausage digit or dactylitis appearance, as you can see in this top photograph. Enthesitis, the Achilles insertion, as mentioned earlier, but also plantar fasciitis and costochondritis are both forms of enthesitis. And then there are mucocutaneous lesions such as psoriasis and mouth ulcers, and you can see the nail changes in the slide below with some psoriatic plaques on the back of the hand and the left fourth digit with a dactylitic appearance. The spinal involvement in these conditions tends to be associated with HLA-B27. So in a patient who has spinal involvement, they have a much higher prevalence of HLA-B27 than the otherwise healthy population, in which it is present in about 9 to 10%. whereas in spondyloarthritis, it may be present in up to 90% of people with ankylosing spondylitis and 70% of people with psoriatic arthritis with axial involvement, with reactive arthritis with axial involvement, and 50% of people with reactive arthritis and axial involvement. This HLA antigen or haplotype is associated with iritis. So these patients often have an increased prevalence of iritis, which is a serious form of inflammation causing a painful red eye and can cause irreversible loss of vision. Reactive arthritis is a form of spondyloarthritis which has some quite characteristic features. For example, it tends to occur after infections. Mostly these can be identified, but not always. As I mentioned, there may be sexually transmitted infections as listed here that may trigger a reactive arthritis. And amongst the causes of infectious diarrhea, Salmonella, Shigella and Yersinia are recognised causes. The extra-articular features in this condition are much more prevalent perhaps than in some of the other spondyloarthritides. The arthritis combined with conjunctivitis and sterile urethritis, so this may occur even without the sexually transmitted infection, is the so-called triad that used to be referred to as Reiter's syndrome and is very characteristic of reactive arthritis. Some of the other features include balanitis, that is inflammation around the head of the penis, and oral ulceration, severe pustular psoriasis on the palms and soles of the feet, which is referred to as keratoderma blennorrhagica and is seen in this image on the right-hand corner of the slide. Enthesiopathy is mentioned previously, and of course sacroiliitis. Turning now to the connective tissue diseases, these include systemic lupus erythematosus, systemic sclerosis, Sjogren's syndrome, dermatomyositis, Meets connective tissue disease, and perhaps form fruits or less severe forms of these conditions that perhaps haven't quite evolved and may never evolve into a form of one of these diseases which meets accepted classification criteria, and we refer to this as undifferentiated connective tissue disease. Now, in some of these patients, there may be true vasculitis, or they may present in a way that looks just like vasculitis, including polyarthritis. In fact, this is probably, broadly speaking, a different class of diseases altogether, some of which are associated with the anchor antibody. I don't have any specific information in this talk about this, but you may read about this later in one of the cases. In general, though, the other connective tissue diseases are associated with antinuclear antibodies. This can be considered a non-specific screening test for most autoimmune diseases that fall under the connective tissue disease banner. It is usually assessed in the first instance using immunofluorescence, in which you're able to identify both a titer, and the values are usually as outlined on the slide, with a very high titer being detectable antibody at a dilution of 1 in 2,560, and also a pattern of staining. So the 4 images here were created from commercial slides of a rat hepatoma, which have obviously nuclei, which are the bright green circles on the slides. And you can see that even though the patient's serum has been placed on these slides and then washed up with a second revealing agent laid on the top, which is an antibody-directed human immunoglobulin, that some of this human immunoglobulin that was in the patient's serum has remained attached to the nuclei, hence the antinuclear antibodies. And you can see that in each of the 4 slides, they appear in different pattern, and this generally indicates that there is binding to different components of the nucleus. So on the left-hand side, in the upper panel, this pattern is called the centromere panel, the centromere pattern, and this is staining due to binding of the patient's antinuclear antibody to the centromere of the chromosomes. And you can see there's one cell there undergoing mitosis where the chromosomes have all lined up in pairs held together at the centromere. On the right-hand upper panel, this is the homogeneous panel. This is the least specific or the most non-specific of the staining patterns. down the right-hand side, the nucleolar pattern of staining, and then on the left-hand side at the bottom, the speckled pattern. And these patterns do have some disease associations. So, for example, the centromere nucleolar patterns tend to be associated with systemic sclerosis, also known as scleroderma. So having identified an anti-nuclear antibody and maybe some other features of autoimmune disease such as Raynaud's phenomenon or abnormal nail fold capillaries in somebody with Raynaud's phenomenon, it's possible to look more closely at the type of anti-nuclear antibody using ELISAs with extractable nuclear antigens in the wells of the ELISA. And combined with clinical features, it's then possible to make a diagnosis of connective tissue disease. So, for example, in SLE, in addition to polyarthritis, there may be increased hair fall, the malar rash across the face, and the antibodies to Rho, La, Smith, and double-stranded DNA. Sjogren syndrome is associated dry eyes and dry mouth, and antibodies to Rho and La. Systemic sclerosis or scleroderma has the anti-centromere antibody, the CNP antibody, and SCL70 and RNA polymerase III antibody. Dermatomyositis, anti-Jo1 and COO, as well as a whole range of other antibodies which require specific testing. Rheumatoid arthritis, which have rheumatoid factor and anti-CCP antibody, and mixed connective tissue disease, which is characterised by the anti-RNP antibody. Just by way of an example, systemic sclerosis is a good example of a heterogeneous multi-organ disease due to three pathological pillars: inflammation, as evidenced by, say, the antinuclear antibody, the arthritis, inflammation within muscle tissue, vasculopathy, which was the Raynaud's phenomenon, and the dilated nail fold capillaries I showed earlier, as well as other changes in blood vessels with narrowing, signs of ischemia with digital pitting scars, digital ulceration, telangiectasia, and these telangiectasia that occur in the gut called gastric antral vascular ectasia. And these culminate in the pathological findings of interstitial fibrosis, which classically leads to scleroderma, which is the thickened, tight skin that starts on the fingers and then moves more proximally. And it's due to abnormal fibroblast production of type 1 collagen with accumulation of a range of long-chain proteins in the extracellular matrix. But this fibrosis is also found in the lungs, causing interstitial lung disease, in the wall of the gut, causing dilated esophagus with reflux, as well as any other component of the gut, renal crisis, myocardial fibrosis, and pulmonary arterial hypertension. And just to round off, there are a range of other causes of polyarthritis. The most common, of course, would be generalized nodal osteoarthritis, as demonstrated in the slide here. And then the small print causes, such as septic arthritis, which more commonly causes a monoarthritis, polymyalgia rheumatica, paraneoplastic syndromes, as already mentioned, and infective endocarditis. So, in summary, rheumatic diseases have the potential to affect multiple systems. The diagnosis can often be made after a thorough history and examination based on the presence or absence of inflammation, chronology and pattern of joint involvement, risk factors and extra-articular features. And it's important to note that whilst investigations are important, they tend to provide supporting evidence only. Thank you for your attention.